Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 14. Welcome to the Pain is Not the Only Problem podcast. Article 14. Pain is not the only problem. Kinesiopathology and gamma gain, Part 2. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Once more, kinesiopathology describes the patient's deficits or defects during movement, the inability to plan and map movement patterns simultaneously performing, number 1, engaged spinal stability, plus number 2, with core neutrality, plus number 3, with proximal to distal sequencing, and with number 4, the accuracy of motor mapping. The kinesiopathic patient athlete will not be able to follow instructions to correct a faulty movement pattern when asked to do so on cue. Instead, they will produce a different movement pattern intending to produce the cued movement pattern, not simply an incomplete cued movement pattern or the wrong movement pattern. For example, when the patient is asked to only flex the knee and approximate the heel to the buttock in the standing position, the patient instead fires the knee flexion and hip flexion. With repeated attempts, the hip is always flexed with knee flexion. The patient can't eliminate the hip flexion. This is a common finding in low back patients and less so with athletes. This objective finding is an important talking point with the patient since it demonstrates how faulty movement patterns can go undetected by the patient and how incorrect yet well-intended patterning by the patient might cause low back pain or delay healing when muscles are not under conscious control and produce motor patterns that are different from their intention, possibly causing injury. With supervised cueing, the patient adapts the corrected movement pattern termed soft wiring, and with practice the movement pattern evolves to a predictable and meaningful involuntary movement pattern that does not need corrective cueing termed hard wiring. This process is valuable therapy to the low back pain patient since it produces meaningful motor mapping. When combined with core recruitment, spinal stability can begin to evolve and the low back pain symptoms should begin to diminish at once. I do not recommend classical orthopedic exams since they are never assessed with the patient in core neutral, and they intend to assess individual muscles or individual joints in isolation while the patient is reclined, what I call corpse-like, and principally concerns reproduction of symptoms, primarily pain. Exams that require goniometer measurements are equally unhelpful since the patient is not performing any specific joint action or performing ADLs or sport-specific movements, and do not explain nor demonstrate the stability of the joint. In human life, individual joints pass through triplanar angles simultaneously and instantaneously. Clinically, a goniometer measurement of the knee while seated on the exam table is a misrepresentation of that patient athlete's knee experience while performing a field cut to accept a football pass. In real life, the external, transmissive, and absorptive forces on joints are not equal to those in casual clinical appraisal. Therefore, the symptomatic findings are never explained as being systems-based, contributors involving myofascial slings, ground force reaction, nor spinal stability. Clinical examination should combine all of the naturally occurring features of the patient's entire experience associated with their complaint, not simply reproduction of symptoms. For example, these are a sample of the drills that my office utilizes to assess and discuss motor mapping defects and deficits. They combine multiple, meaningful clinical findings within a single drill. First, let's look at the rhythmic stabilization drill. Rhythmic stabilization of the trunk is performed at the shoulders. In the standing core neutral position, the patient is instructed to maintain that shape while the clinician perturbates them into accelerated alternating rotation 5 times in each direction. This is the push-pull effect. 5 times push-pull to the left, 5 times push-pull to the right. The fault responses include 1. The patient does not resist with stability, known as underreaching. 2. The patient aggressively counter-rotates, known as overreaching. 3. The patient preloads rotation without any stimulus. So this is before the clinician actually creates the perturbated load. This is known as prediction reaching. This drill is excellent for assessing motor map preparation and execution with an external load, as in fall prevention. Next, let's look at 2, trunk rotation. Trunk rotation is performed in the standing core neutral position. The patient is instructed to rotate the trunk to the left and to the right 5 times without hip rotation. The fault responses include 1. The hip follows the trunk into rotation. 2. The knees follow the trunk into rotation. 3. The arms pass into rotation but not the trunk. 4. The trunk rotates and the arms pass into rotation. This drill is excellent for assessing motor mapping of dissociated motor patterns of the outer unit myofascial slings. In this case, the upper body is mobile while the lower body is stabile, common in many sports. Next, let's look at 3, the buttocks kick. Buttocks kicks are performed in the standing core neutral position. The patient is instructed to flex a knee and touch the buttock with the heel. It is not important if the patient can't reach the buttock with the heel. With the foot, dorsiflex, 5 times on the left, 5 times on the right. The fault responses include 1. The hip and the knee are flexed. 2. The foot is plantar flexed. 3. The patient loses balance. 4. The patient refuses to perform the drill due to expectation of low back pain. This drill is excellent for assessing motor mapping, preparation, and execution concerning specificity. Specificity meaning only the muscles that are required to perform the drill are fired. It is common for low back pain patients to misfire the flexors and extensors of the legs, indicating pathological central processing. Next, let's look at 4, the flat back fold. The flat back fold is performed standing in the core neutral position. The patient is instructed to flex the trunk at the hip to 90 degrees while maintaining a forward gaze with the hands clasped together behind the back and without rounding the thoracic spine. This is performed 5 times. The fault responses include 1. The patient can't maintain forward gaze. They look down. 2. The patient can't clasp the hands behind the back due to internal rotation of the shoulders, not because they don't know how to do it or can't do it, maybe because of a girth issue. 3. Patient can't maintain flat thoracic spine. The back is rounded. 4. The shoulders internally rotate at any point of the drill, even if the hands are clasped or not clasped. 5. The knees bend greater than neutral. 6. The patient can't flex to 90 degrees with or without any other faults. And 7. The patient refuses to perform the drill due to expectation of low back pain. This drill is excellent for assessing the limitations of upper and lower cross syndromes simultaneously and how inflexibility contributes to ADL limitations related to low back pain. Next, let's look at 5, the reverse gait stepover. The patient begins this drill in the standing core neutral position. The patient is instructed to step forward with one foot. This becomes the posting leg and posts into stability. Then flexes the other hip. This ipsy hip is then internally rotated to 90 degrees while they extend that same ipsy bent knee leg behind them with the knee flexed and the foot dorsiflexed and step back into a shallow lunge, 5 times on the left, 5 times on the right. This drill simulates stepping over a hurdle in reverse. The fault responses include 1. Stepping into a narrow stance and losing balance, either when they step forward or when they step to the reverse. 2. inability to internally rotate the leg to any degree. Number 3, the patient does not use the arms to add a balance feature or just loses balance. Number 4, the posting leg knee shifts valgus. Number 5, the posting leg foot pronates. Number 6, the flexed leg hip drops rather than stacks. Number 7, the knee is higher than the foot during the leg extension. And 8, the foot loses dorsiflexion at any point in the drill. This drill is excellent for assessing sequencing, hip mobility, and balance. It is common for patients to experience cramping, weakness, and frustration with this drill. Record any patient language that demonstrates emotionality with this drill. This drill is difficult, and it is for every patient, not just advanced patients or athletes. Now let's look at number 6, the overhead squat. The overhead squat is performed in the standing core neutral position, and the patient is instructed to perform 5 squats to a depth of hip alignment horizontally with the knees with a flat back. During the squat, the arms are held overhead with the palms facing each other, the fingers pointed upward. During the squat, the heels must remain on the floor and the gaze must remain forward at all times. There are 10 defined parameters of the overhead squat. These are the fault responses. Number 1, depth of squat is not attained. Number 2, the arms fall forward, not reaching upward. Number 3, the gaze drops at any point, even momentarily. Number 4, the chin tucks. Number 5, the chest drops forward. Number 6, genu valgus. Number 7, the feet pronate, especially at the lowest point of the squat. Number 8, heels rise from the ground. Number 9, severe spinal extension. Or number 10, the patient falls backwards attempting to set the heels. These are the 10 standardized specifications for the overhead squat. This drill is excellent for assessing whole body movement compliance and how the many interconnected motor drivers can learn to coordinate to prevent faulty motor patterning related to low back pain. Notice that each of the drills that we use in our office begin with patient preparing in the core neutral position. In fact, every patient assessment must be performed in the standing core neutral position with the core engaged and with clear instructions given all at once, never lying down on an exam table or seated. Even if the exam is about the elbow, it must be performed standing and in core neutral. The patient is not cued nor coaxed through the drill. They are given the instructions and are required to remember them. The drills are not demonstrated in any way. In my office, we read the instructions from a cue card on an iPad. In certain cases, we video record the patient on a secure device to provide feedback and archive the event for future reevaluation. Common contributors to kinesiopathology include frank injury, subthreshold microtrauma, articular fixations described as capsular restrictions, degenerative changes, elective mobility, lesion, fusion, onset alignment changes, and organic disease. Other contributors include the recuperative and reparative processes, healing insufficiency that leads to proliferation of neural and vascular density, oxygen starvation as in trigger points, inflammatory mediators, chronic strain to tissues. Contributors also include insufficient nociception mediation, propagation of wide dynamic range cells, and possibly ephaptic signaling. And finally, consider sympathetic amplification that stimulates the RAS and therefore SNS attention to pain, leading to muscle tone tension, sympathetic atonia, increased respiration and blood pressure, emotional changes, mood, guarding, and trigger points. Pathology related to movement is the primary interest of the low back pain patient, not pictures, not pencil erasers, not pain, and not pills. Since core neutrality is the primary support system of the spine, it must be understood if it evolves pathologically. Neutral fault progression describes joint instability and motor faults due to the patient's inability to manage movement patterns, which then leads to number 2, elective immobility or reduced active range of motion, which leads to number 3, organic hyper and hypomobility, the recruitability that leads to any active range of motion, which then leads to number 4, chronic underdiagnosed subthreshold microtrauma, which then leads to number 5, ischemia and spasm, which then leads to number 6, adaptive shortening or gamma gain, which then leads to dendritic adhesions and scarnitis, which then leads to number 8, hyperactivity and upregulation via arc reflexes, which then leads to number 9, overload of the HPA axis and the sympathetic nervous system, which delays healing, which leads to 10, pain and symptoms. Since pain and symptoms occur at the end of the neutral fault progression, treating only pain does not address the other 9 factors within the progression. Therefore, neutral fault is never addressed nor corrected, leading to perpetuated clinical failures and patient dissatisfaction and high costs. Adaptive shortening, as described in the sequence number 6 of the neutral fault progression, is also known as gamma gain. This is the sensitivity of the gamma motor neuron background discharge taking place within a muscle cell relative to the alpha motor neuron. The alpha motor neuron is responsible for active contraction of the muscle via central control, also known as corticospinal, whereas the gamma motor neuron is responsible for maintaining an on-demand pre-contraction or continuous resetting of the equatorial muscle spindle in order to maintain muscle tension as the muscle contracts or gets shorter, and the belly shortens in order to provide work, informing the muscle spindle to maintain tension gain. Pathologically, constant gamma discharge, as described in the neural fault progression, stage 6, produces constant stiffness and functional range of motion resistance. Gamma gain or increased tone to muscles controlling joint motion will change meaningful movement patterns into movement faults and likely compress joints, limiting glide, slide, roll, and spin. The gamma motor neuron takes its cues from the alpha motor neuron. The gamma motor neuron provides 2 functions. Number 1, statically, described as magnitude, in order to produce and maintain posture, slow focus control, and stretch reflex. And 2, dynamically, described as velocity or speed, in order to produce direction change, acceleration, deceleration, and manage joint torsion, load, and shear. Classical physical therapy is slow, cautious, reductionist, and primarily focuses on pain reduction. Classical physical therapy would not be able to address any issues of gamma gain because the treatment plan is very slow and doesn't include acceleration, deceleration, sudden direction change, or manage joint torsion, load, or shear. In order to address the low back pain contributors of neutral fault, the clinician must address the patient while standing in core neutral and while performing multi-joint complex motor patterns that seek to expose instability and limitations of range, stretch, balance, direction change, responsiveness, coordination, and relevancy all at once. Multitask drills with a lively deliberation of the results and findings is the best way to cultivate patient trust and willingness to accept the clinician's advice to move forward with managed conservative care, since pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.